بيكم يا دكاتره النهارده in Techno Pharmaceuticals webinar. تكنو احدى شركات فاركو، اول شركه مصريه متخصصه في الفيميل هرمونز. تكنو has a wide portfolio of oral contraceptives، منها الفيموجزال، النوجستاديول، التكنوسبايرون، ومؤخرا المارتا فيفا the first and only Dynogest ethinyl estradiol in the Egyptian market. First, let me welcome Professor عمرو and Professor أبو بكر. Professor عمرو نوري النهارده إن شاء الله هيكلمنا عن الإمباكت of COVID-19 on family planning، وبروفيسور أبو بكر إن شاء الله هيتكلم عن الرول of Dynogest ethinyl estradiol in family planning. Let me welcome Professor عمرو النوري, Professor of Obstetrics and Gynecology and Infertility and the Fellow of the Royal College of Obstetrics and Gynecology and the Fellow of the Royal College of Surgeons. Welcome Professor عمرو, the mic is all yours.
Ladies and gentlemen, it gives me the great pleasure to join with you in this webinar. My name is Amr El Nouri. I'm professor in obstetrics and gynecology and fellow of the Royal College of Obstetrics and Gynecology and also of Royal College of Surgeons. Welcome, and we are going to talk about the impact of COVID-19 on the family planning. So I hope that you are staying safe at home. COVID-19, really everyone now is talking about COVID-19, and it is really affecting everyone. Every daily life, you know, is really affected with the COVID-19. This picture of Wuhan, a city in China, where the first time the coronavirus is become known. It is a city that's known of innovation. So there is a novel coronavirus appeared at the end of December, first in an animal market, and then started to find cases of severe respiratory distress. And then they discovered the coronavirus. And this coronavirus, really, it has the shape of a crown. And the name of crown in Latin is corona. That's why it's called corona. And it is very similar genetically and structure-wise to the SARS virus that was discovered in China in 2003, and also to the Middle East respiratory virus in Saudi Arabia in the Middle East in 2012. And if you look at this table in 2019, 2020, from December till now, it's nearly 6 months, you know, only, and there is more than 464,000 deaths all over the world. And this is the SARS, the severe acute respiratory syndrome, and this virus is an enveloped virus, RNA genome, and it has, as you can see here, there are protein spikes that this is attached to the cell, to the receptor of the ACE2 receptors. And because of the virus is very close to the SARS virus, so they call it CoV-2 or coronavirus 2. And this is the virus that's causing the disease. But the word COVID, it is the short name of the coronavirus disease, abbreviation of each letter. So you got the COVID-19. It was discovered in December 19, so it was called 19, despite the nomenclature actually was given in 2020 by the WHO. Well, the cumulative number of deaths really is very high, and there are now more than 7 million, approaching 8 million cases of confirmed cases of infection with corona. And yesterday only there were 422,000 all over the world. And if you look in Egypt, till yesterday, there are approaching 40,000 confirmed cases, and yesterday only there was 1,442 cases of coronavirus. The number of deaths is very high. It is 4,064 till yesterday, 1,000 cases, and only yesterday there were 46,000 cases of deaths. In Egypt, the total number of deaths since the coronavirus is 1,377, and yesterday were 35 deaths. So it's really having an effect severe on the community internationally and nationally in Egypt. Even in the United States, till yesterday, which is the day 80 for USA for the coronavirus, there are nearly 111,000 plus cases of death all over the world. So you can see really the scope and the effect of this COVID on life, all over the world. The transmission is known by the aerosol respiration and also secretions from the feces, the urine, and the vomits, or contact from contaminated surface, such as the mobile phones. Some talks about this, but still this is the accepted way of transmission. And there is a probable vertical transmission, not a very strong evidence, but there is a probable vertical transmission. And there is no evidence of transmission via the genital fluid, despite there is a paper that they found the coronavirus particles in the semen. But this does not mean that this is infection carried, because it is present in other places like the feces, the urine, and other body fluids. The symptoms really, they are varies from mild to severe, but 85%, thanks God, are mild symptoms, cold and flu-like. And the most common is the fever in 99%, more than 37.8, and then cough in nearly 60%, and then shortness of breath is in 31%. But there are other less common, like the loss of smell, the headache, the muscle pain, the tiredness, the diarrhea, the nausea, and vomiting. The incubation period is 1 to 14 days, with the mean time of 5 to 6 days. The course really is important because you find here that 85% of the cases, they will have really no symptoms or mild symptoms, and then after a maximum 10 days, they will become immune. But remaining 15%, 10 of them will become severe symptoms, become hospitalized, but no ventilation, and will become immune. The problem in this 5% will have severe symptoms and then become hospitalized, ICU, ventilated, and half of them will die. And actually, most of this actually is the immune compromised and patients, and because the virus really is well known that it will affect or infect more of the young adults, but will kill more of the old and immunocompromised. This is the definition of suspected cases. Those are coming from travel from infected countries or infected communities. They need to be isolated, or those who had been in contact with people who had coronavirus, RNA positive, but also those who are really having a severe respiratory infection, severe acute respiratory infection, and knowing this by the hypoxia and oxygen saturation, where the oxygen saturation will become less than 94 in the room temperature. And these are the clinical tests that are done. The most common symptom is the fever, but there are other symptoms as well. And these are the tests that are done, from the immunoglobulins to the full blood picture. And there are other markers. We look in the full blood picture, the lymphocytes, if they are low lymphocytes, and the normal white cell count. But other markers are the very high ferritin, the very high CRP, C-reactive protein, and the D-dimer and LDH. An imaging characteristic of the CT scan, really, of the ground glass appearance, is characteristic of the virus. So if you have really all this, really, then you diagnose the corona or the COVID, and you can take at the end the this nasopharyngeal swab looking at the PCR, but it's not available everywhere. And I understand in Egypt, for example, there were 140,000 almost cases of diagnosed by the PCR. So what's the effect of COVID-19 on the family planning? Well, it affected every health service. So we would expect that it will affect the family planning service. We know that there is restriction on the public movement, there is lockdown, and even if there is a movement outside the lockdown, some of them are really afraid and they are staying at home and they do not want to leave the house. In the same time, there is increasing pressure on the National Health Service facilities, so they give prioritization to the isolation and to the intensive and care facilities. And even many hospitals all over the world, they closed the routine gynecology service and non-essential services, and they are thinking how to reopen this later on. So the family planning has become inaccessible to many of the women. And we are in the mood of the crisis mood, so it's relatively easy to shut down, and the prediction that this crisis will continue is not really, we cannot see it. It may stay for a month, a year, it may open and they may close again, so the effect really is, impact is high. So it affected every government, every health organization, including family planning and contraceptive services, and you can see that there are nearly 7 million more unwanted pregnancies during the COVID-19. And the more actually you will increase the lockdown, the more that you will get more unwanted pregnancy that can reach up to 15 million. So we are losing access to the modern methods of contraception due to the impact of impact on many family planning services. The FIGO statement really is the contraceptive and the family planning services and supplies are core component of essential health services, and access of the services is a fundamental human right and reproductive health right. But if you look what's happening now from the COVID-19, it's affecting the provision of the basic contraception counseling, the delivery of contraceptive products and services, and even the functioning of the supply chain already have been disrupted, and men and women are at a disadvantage in seeking care from their regular providers. And counseling really is very important, because should we get pregnant and what's the effect on pregnancy? And we know that pregnant women in general are vulnerable group because of the immune changes that occur during pregnancy and their vulnerability. But the good really thing that the effect of pregnancy, the clinical outcome of pregnant women with COVID-19 is relatively optimistic, except in those with comorbidity, with the older age, with the diabetes, with the chronic lung problem, or renal disease, for example. And there might be an association with the HELLP syndrome. And the good thing also, the effect on the fetus, that it may actually, there is a probable vertical transmission, but there is no conclusive evidence. It's not been found in the amniotic fluid or in the placenta. And there is no increased risk of miscarriage, and it is not teratogenic. And however, there are reports of preterm birth, and this is mainly iatrogenic to save the mother, to deliver the mother with severe respiratory problems. So the outcome is relatively optimistic. But this is very important, so the patient really can have the information whether to go for pregnancy or to go choose to go for contraceptive methods, during this crisis of COVID-19. Even the key societies for infertility, they are not encouraging people actually to go for this treatment to get pregnant, and they are from ESHRI to ASRM and asking to avoid becoming pregnant, considering deferring pregnancy, and really to minimize the impact of on the resources of the National Health Service. So if you look here, the effect of COVID-19, the lockdown measures actually stopped people from going to work, stopped factories, in China, in other places. The isolation measures, half the workforce, is started to be there. So there is reduced capacity, stopped production of many of the contraceptives that are coming from different countries, from China, from India. For example, the progesterone export was put restriction on it, in India. And even the time, the delivery and shipment, there are delay in the shipment. And if you want to read it, if there is a deficiency of contraceptive, for example, in one country, the registration in the health with the health authorities take a long period of time, may take sometimes months or years. So it's really affecting. And also the message that are given from meetings to the health providers and doctors, they are not available anyway now. But with the online change now, there is a change of the COVID-19 with the use of online service, exactly that we are using today. So there is disrupted contraceptive supply chain as a result of the COVID-19. And the impact of this on suspension of family planning services, unwanted pregnancy, as we said, from 7 million to 15 million cases, or morbidity from inappropriate use of contraception without looking into the medical eligibility criteria, and the morbidity and mortality from the pregnancy that will occur unwanted on the newborn and on the maternal mortality, increase the sexually transmitted disease and the unsafe abortion, and it is problem as well, So the COVID and the contraceptive methods, the patient wants really either to initiate, start a new method, or continue a method that she is having, or switching to another method, or stopping a method. And all these are rights for the patient. And nowadays, really exactly similar to the online meetings now, there is a telehealth and telemedicine. And this has started actually to develop in some of the countries, and mainly done for non-essential services, and even for essential services for the counseling and discussion. So you can do this video consulting with your patient and face-to-face meeting with these patients. And the medical eligibility criteria, in some, there is no restriction on the use, they give it 1. The advantages outweigh the risks, but you can use it if the advantages outweigh the risks, 2. But there is risk usually outweigh advantage, is 3 here, the amber color. And the red color here is unacceptable, that should not be used. And one should really actually look for every contraception and the medical eligibility criteria, or medical health problem, and also the medical eligibility criteria. So what's the COVID can affect us, Really the method initiation. Many of the people that initiate the method sometimes is immediately after pregnancy, And this is really a time there is a high motivation to postpone the pregnancy. But many of them really actually will start intercourse early, before the 6 weeks. And some of them, actually 50%, will not use the method they intended to use. So that we have a golden opportunity to discuss contraception during the 3rd trimester of the antenatal visits and document this. And maybe actually you think about the LARC, the long-acting reversible contraceptives. For example, immediate postpartum intrauterine device insertion, or you look about hormonal contraceptive, whether it is implant, progesterone, or combined hormonal contraception. And you can actually insert the ICD immediately postpartum. And the immediate postpartum insertion, it's easy. You don't actually use the normal insertion of the ICD, but you use like an ovum forceps without locking the ovum, and you hold it with the T-shape is open, and you insert it inside, but you don't lock the ovum forceps and then you put it till the fundus, and then you open, and then rotate it, get it to one side, and then remove it, and you cut the thread only to be around maybe 10 centimeter. And you can also do it by manual insertion. You put it between the 2 fingers with the transverse arm, as you can see here, open, and you insert it till the fundus, and then you hold it with the other finger from the abdominal side, and then you remove your finger and you cut it short, the thread. And you have to do this within 10 minutes of delivery of the placenta. So this is the immediate post-placenta. And you can do it even during the cesarean section, either directly by the, if you are going to put the progestogen-loaded contraceptives, or by the ovum, or by hand. And again, you don't lock on it, and you put it inside the uterus till the fundus, and you guide the thread to the cervix. And this is very important to reduce the chance of expulsion. We know there is increased the risk of expulsion of around 20%, but the effectiveness of the LARC methods has been proven to prevent pregnancy. And sometimes the patient will come to you during the COVID and they want to continue or replace the method. So it's now agreed that when you have to counsel on the extended use of the long-acting reversible contraceptive. We know the Implanon is only for 3 years, but it can stay up to 5 years here. And the progesterone is 5 years, like loaded progesterone, 5 years. This is the Mirena, but there is others. The Kylina, for example, is 3 years. But this one can extend from 5 years. You can leave it to 7 years. So if the patient comes to you, you can tell her, well, you can leave it up to 7 years. The copper IUD can stay up to 12 years. And this is in the COVID time. And if the patient fitted any of these, before the age of 45, they can use it up till the age of 55. When you give contraceptive pills or hormones, you need to give a prescription for a long period of time, 3 to 12 months, because the patient will not be able to come to renew the prescription every time. And if you are using injection, maybe you can use a subcutaneous injection so that the patient can give herself, every month, the injection. Sometimes with the prescription, it's better really to give a backup method, especially for the first 7 days if you are using these methods. And when you stop the method, if the patient wants to stop the method, it is her right. And it's considered as an essential service and the human reproductive health right. And we should give her a point as early as possible to remove the long-acting reversible contraceptive after, of course, counseling of the patient. So the appointments during that time, really, we know that everyone should observe the social distancing. And before entering the facility, there should be a triage. When they open the facilities and release the suspension of some of the gynecological services and the family planning services, and delay the visit if there are symptoms. For example, if there are symptoms, you delay for 7 days. If there is no symptoms and there is household having symptoms, then you defer for 14 days. But you give an appointment after that. You minimize the examination time. Take your personal protective equipment, and maybe we start to use video online or telehealth, telemedicine, and respect confidentiality, of course. In the facility, the general protective measures should be applied, washing the hands on entering the facility, and access in all locations to washing hands and sanitizers and alcohol sanitizers. If you are going to see a new patient, you have to wash your hands before and after the physical examination, and once the woman leaves. We need to keep 2 arm length distance. However, we do the normal clinical examination. Washing the hand is, of course, important, very important, and the safety measures to be taken. The personal protective equipment in the contraceptive, the routine care, we use a mask. We don't use an N95. The gloves, apron, and the eye protection. As there is no really aerosol generating procedure in cases of contraceptive insertion. So, but only the essential stuff should be in the room and the partner to be excluded. And if you are doing an ultrasound scanning, also you should use this and make it to the minimum time. For the telemedicine, we can designate specific services for the telemedicine, either by telephone or video consultation. And there is a full range of method. Counseling should be done by the telemedicine and the face-to-face or the telephone. We should also advise about the bridging methods or temporary methods till they are able to receive or start the chosen method when the situation allows. Progesterone-only pills is a good option and can be started without too much really difficulty, and can be done because it can be done in many situations, even in cases of, for example, history of deep venous thrombosis, for example. In some of the countries now, they prescribe the contraceptive methods online, so they send it online to the pharmacy and the patient go and collect it. And maybe they are thinking about posting this in the future as a home delivery to improve the patient compliance with this, we can counsel, as we mentioned earlier, on the extended use of the LARC methods and also on the emergency contraceptive prescription. The only thing for not using this is insertion or removal of long-acting contraceptive methods. The medical eligibility is really very important, as we mentioned. And I'll give you a scenario, for example, here, just to about the medical eligibility criteria and also the use of online application. This patient is a 35-year-old, has a history of migraine headache with light sensitivity. She does not experience any visual warning signs for coming headache. She's interested in starting contraception and what methods are safe for her to consider. And I leave you for a few seconds to choose one of these methods. Well, actually, they are all of the above, so long as she does not have other risk factor for stroke. For example, if there is a risk factor for stroke, then you will choose the IUCD and the progesterone-only pill. But this patient has no aura or has no visual. And there are applications now, actually you can look for the application. For example, here we looked at the progesterone, the headache, and here we look if it is migraine. Okay, it's a migraine, but it has no aura. So in this case, they give the medical eligibility criteria. It's 111, and the advantage outweigh the disadvantage, the risk. You can give still the hormonal, continuous hormonal contraceptive pills, and you can click here and you can give actually the clarification why this decision. So this will help you actually in taking the decision and knowing that you are really up to date with this. So the telehealth visits really and family planning, they are really important. They are not only improve, but will also empower the social distancing. People can stay at home. The medical doctors can actually sometimes stay at home when they are isolating, and they can provide the service from home. You reduce the risk of exposure of the COVID-19, but it really needs some privacy regulations and payment policies. And also it preserves the staff availability, decrease the risk, as we mentioned, to COVID-19, and also preserve the personal protective equipment for the high priority patients. As we mentioned, you can give the counseling, the method initiation, continuation, and switching, and you may give the electronic prescription by online in some of the countries, and in the future. I'm sure this will be the future. We need to make sure that the capacity for the family units and the staff members really are okay. And because we know that during that time there will be shortage of the staff, either asking them to isolate, and also there might be potential shortage of personal protective equipment. And this all need to be discussed for the workforce, and daily discussion to review the service provision and available staff. And we should maximize the use of telehealth and telemedicine as possible. And I'm sure we'll develop new counseling and clinical skills and online training in the coming period. The key messages read that COVID-19 is expected to disrupt the family planning services, and the longer it will be extended, the lockdown and the crisis, the more effect on the family planning service. We need to ensure the supply chain and the supply of modern contraception and social distancing and limitation on mobility. There is a consideration of LARC that should start actually from the time of antenatal care in the 3rd trimester, and the self-care family planning method should be promoted and given proactively for a longer period of time from contraceptive hormonal pills, self-injectables, and even emergency contraception. And we need to implement the telemedicine to improve the information and access to contraception, and healthcare workers must be provided adequate personal protection equipment. And lastly, the COVID-19 must be the government priority. Not only this, but also the family planning and reproductive health should be continued and supported. Thank you very much for your attention. Please stay safe, use sanitizers, alcohol sanitizers after seeing every patient, and I have to use the mask as well. Take care.
Professor عمرو النوري for the very rich content. اعتقد احنا كده we covered كل الاسئله اللي ممكن تخطر في بال اي حد عن الكوفيد 19 والامباكت بتاعه على الفاميلي بلاننج، وكمان الامبورتنس اوف الاورال كونترسبشن او اوف الكونترسبتيفز ميثودز خلال الفتره اللي بتمر بيها مصر دلوقتي. بمناسبه الامبورتنس اوف فاميلي بلاننج او اوف اورال كونترسبتيفز، احب ارحب ببروفيسور ابو بكر النشار اللي هيكلمنا النهارده عن الرول اوف داينوجست اثينال استراديول on family planning. Professor Abu Bakr al-Nashar is the Professor of Obstetrics and Gynecology, Banha University Hospital, and the President of the Clinical Society of Obstetrics and Gynecology. أهلا بيك بروفيسور أبو بكر. بليز يا جماعة لو حد ليه أي أسئلة لبروفيسور أبو بكر أو بروفيسور عمرو يا ريت يحطها في ال Q&A تاب اللي موجود تحت، وهم هيجاوبوا على أسئلتكم في آخر البرزنتيشن إن شاء الله. بروفيسور أبو بكر أهلا بيك. The mic is all yours.
Bismillahirrahmanirrahim. I would like to thank Techno Pharmacy for inviting me to deliver this lecture in this webinar. You can get this lecture and more than 450 lectures from my scientific page on the Facebook and also from the SlideShare website. We will discuss today ethinyl estradiol Dionogest contraceptive pills. I will address 4 items. After the introduction, what is the pharmacology? What is the effects? What is the contraceptive efficacy? And the most important is the safety. So we will discuss pharmacology, effects, efficacy, and safety. And at the end, the conclusion. Let us start one by one. The Dionogest ethinyl estradiol is a low-dose monophasic combination containing ethinyl estradiol 30 microgram. Why 30 microgram? To ensure satisfactory cycle control and to keep estrogen-related adverse events to the minimum. We have 2 milligrams of Dionogest and this will cause sufficient inhibition of ovulation. As we know, we have 4 generations of progestogen. The first generation, second generation, third generation, and the fourth generation. And one of the important fourth generation is Dianogest, which is available in Marta Viva. What is the difference between the new progestogen and the old progestogen? For the new progestogen, there is a comparable with old progestogen as regards the breakthrough bleeding and amenorrhea. But with the new progestogen, there is less androgenic and less adverse effects on the lipids. And there is negligible impact on the carbohydrate metabolism. So we have, it is less androgenic and less adverse effects on the lipid and no impact on the carbohydrate metabolism. If we compare it between Dianogest and the other progestogen, and you will see here the progestogenic effect is good, the anti-androgenic activity is good, and the androgenic activity, no androgenic activity, and the glucocorticoid activity, there is no glucocorticoid activity. And this all of the advantages of the Dianogest compared with the other progestogen. What is the mechanism of action of the combined oral contraceptive pills? As we mentioned, it contains ethinyl estradiol and the progestogen. And the ethinyl estradiol will cause decrease the FSH and LH. And this will cause no follicular development and no ovulation. Also, the ethinyl estradiol will maintain the endometrial thickening, and this will prevent the breakthrough bleeding. The component of the progestogen also will decrease the FSH and LH, and this will cause no ovulation. The progestogenic component has important function on the cervix. It will cause decrease in the cervical mucus and makes cervical mucus viscid, and this will prevent the ascent of the sperm, and this will prevent fertilization. So the mechanism of action on the ovary, on the cervix, and on the endometrium. Let us, after this short introduction, to go to, as we mentioned, we will discuss the pharmacology, then the effects, then the contraceptive efficacy, then the safety, and after that, the conclusion. As regards the pharmacology of Dianogest, it is very unique, and Dianogest is the only non-testosterone derivative which has a cyanomethyl instead of the ethinyl group at the carbon 17. If you look here, there is no ethinyl group, but there is a cyanomethyl group. And this will cause the strong, it is the cause of the strong progestogenic effect on the endometrium. And as we will see, it is 17 times more effective on the endometrium compared with the other progestogen. Dianogest there is a less pronounced anti-gonadotropic action, and there is absence of estrogenic and androgenic activities. Dianogest has anti-androgenic action. Dianogest daily dose is necessary to inhibit ovulation, and this dose is 1 milligram. Dianogest, there is no binding affinity to sex hormone binding globulin or the corticosteroids binding globulin. Dianogest bound with low affinity only to albumin. One of the important characteristics of Dianogest is the anti-angiogenic and the anti-proliferative and the anti-inflammatory effect. And as we know, this is one of the theories of the endometriosis. And that's why it is beneficial in endometriosis, because it will cause atrophy of the ectopic endometrium. Let us go to the second item of my lecture today, is the effects. So the first one was the pharmacology, and second is the effects. What is the effects of Dianogest acenyl estradiol combined oral contraceptive pills on lipid metabolism? There is a minor influence, and the effects are favorable rather than unfavorable. There is increase in the HDL. There is a slight change in the levels of LDL, and there is significant reduction of the lipoprotein. So the effect on the lipids is favorable and not unfavorable. What is the effect on the carbohydrate metabolism? Changes in the carbohydrate metabolism are within the normal range. There is a slight increase in the fasting insulin, and there is no significant increase in glucose, no significant increase in hemoglobin A1C, or in the ratio of the insulin glucose. But we should keep in mind, in predisposed women, it may cause glucose intolerance. It's very important to know the effects on the homeostasis. As regards the factor 7, there is increase by 20%, and for protein C, there is a slight increase by 10%, and for the plasminogen, there is increase by 30%. So all individual values stayed in the normal range, and therefore without clinical relevance. In healthy users, the use of the Dianogest acenyl estradiol combined oral contraceptive pills, it is not thrombogenic. But in predisposed women, there is a risk of thromboembolic disease. This risk might increase, and we should take care in this condition. But this risk is comparable with the other low-dose oral contraceptive pills on the thrombosis. What is the effect on the body weight? There is a minimal impact on the body weight. There is a small increase by only ½ kilogram on the average. And this small increase is similar to changes found with the low-dose oral contraceptive pills. What is the effect on the blood pressure? There is no significant change in the blood pressure. And the development of hypertension was found in a small proportion of women. It is only found in 2.5% during oral contraceptive use of the Dianogest acenyl estradiol combined oral contraceptive pills. What is the effect on the cycle control? As we know, the most common cause of stop of use of combined oral contraceptive pills is the intermenstrual bleeding or absence of withdrawal bleeding. But the clinical studies found that the Dianogest acenyl estradiol contraceptive pills, there is a good cycle control. The intermenstrual bleeding in the first 3 cycles is only 3 to 5%, and after that the intermenstrual bleeding decrease, and it is less than 1%. As regards cycle length, it is unchanged and at around 28 days. The duration of the menstrual bleeding shortened from 5 days at baseline to 4 days after 6 treatment cycle, and this is beneficial. The cycle control is high, and the duration of the menstrual bleeding will decrease to 4 days. And this study showed, and this study included 16,000 women and showed how the spotting and the breakthrough bleeding is decreased with the use of the combined oral contraceptive pills, Dianogest, ethinyl estradiol. The intensity of the bleeding or the severity of the bleeding is also reduced, and the frequency of dysmenorrhea is decreased markedly, and this is one of the benefits of the use of the Dianogest ethinyl estradiol. Absence of bleeding only in 3% of the treatment cycle. So we can conclude that cycle control is comparable with the other low dose combined oral contraceptive pills. And this study shows the incidence of dysmenorrhea during 6 months. As we see here, at the start, it was 28%, decreased to 12%, and with continuing of use of the Dianogest ethinyl estradiol, it markedly decreased, and this is one of the benefits of the use of this contraceptive pills. What is the effect on the acne? As we mentioned, it is anti-androgenic, and there is improvement of the acne in 87% after 6 cycles. Not only the acne, but the area of the sebaceous gland significantly decrease. So the ethinyl estradiol Dianogest is equipotent to the combination of the 35 ethinyl estradiol and 2 milligram cypritrone acetate. As we know, this is one of the combined oral contraceptive pills which was recommended to be used in the treatment of the acne. And according to this study, the Dianogest ethinyl estradiol was comparable and equipotent to the contraceptive pills containing cypritrone acetate and the ethinyl estradiol. The greasy hair, there is an improvement in 70%. The greasy skin, there is an improvement in 81% after 6 cycles. So we can come to the conclusion, ethinyl estradiol Dianogest particularly suitable for treatment of women with androgen-dependent skin disorders, the acne, the greasy hair, and the greasy skin. And this shows, the study shows the effect of ethinyl estradiol Dianogest on the acne, and as we see here, this a marked improvement in the acne after the use of Dianogest ethinyl estradiol. So we addressed the pharmacology and we addressed the effects. What is about the most important point? The most important point is the contraceptive efficacy. Let us go to the 3 European clinical studies evaluating the efficacy, and this included 3,000 subjects and about more than 38,000 treatment cycles. The pregnancy occurred only in 17 ladies, and so the unadjusted Pearl index was 0.5, and 6 of them result from method failure. As we know, we have the method failure and the user failure. So the adjusted Pearl index was 0.19 pregnancies per high woman per year. Another study, including 16 92,000 women, including 92,000 cycles. The pregnancy occurred 11. So the unadjusted Berle index was 0.14 only. 4 of them was due to user failure. So the adjusted Berle index was 0.09, less than 0.1 pregnancies per 100 women year. So the success rate is more than 99%. This is very important. The contraceptive efficacy is high. It is more than 99%. And the adjusted Berle index is less than 0.1. So we can conclude that the ethinyl estradiol Dianogest is a reliable ovulation inhibitor, and its contraceptive efficacy is comparable to the other low-dose combined oral contraceptive pills. But may one ask, what is the causes and what is the mechanism of this high efficacy, the high contraceptive efficacy? It is attributed to the synergistic effect between both the ovulation inhibition, the fertilization inhibition, and the implantation inhibition. Let us go to the ovulation inhibition. The ovulation inhibition is attributed to the reduction of the LH and FSH, and the inhibition of the follicular maturation and inhibition of ovulation. The fertilization inhibition is attributed to the effect of the progestogen on the cervical mucus, decreasing its amount and increasing its viscosity, and so it will prevent the ascent of the sperm. And the implantation inhibition is attributed to the potent gestagenic activity of the Dianogest on the endometrium. The endometrium will be thin, and this will prevent the implantation of the embryo. So we have ovulation inhibition, fertilization inhibition, and implantation inhibition. If we go to the studies, the study attributed the ovulation inhibition to the suppression of the LH and FSH. It is a randomized study, and we see here how the LH is inhibited and how the FSH is inhibited. The ovulation inhibited is attributed to the suppression of the serum progesterone, and this study, which was a randomized multi-center study examining not only the effect on the progesterone but also the safety and the efficacy of the Dianogest ethinyl estradiol combined oral contraceptive pills, included 93 women, 531 cycle, and no pregnancies occurs in this 531 cycle. And as we see here, this is the serum progesterone level and how it is markedly suppressed by using of the ethinyl estradiol Dianogest contraceptive pills, and this will lead to the high efficacy, the high contraceptive efficacy of the contraceptive pills. Also, the high efficacy of the as a contraceptive is the implantation inhibition, and this can be seen by this study. It is through its potent thinning effect on the endometrium, making the endometrium less receptive to the embryo. Dianogest effect on the endometrium is 17 times the effect of the older progestogen. And this study comparing the different progestogen with Dianogest, and as we see here, the Dianogest is 17 times effect on the endometrium compared with the older progestogen. Again, we want to illustrate the mechanism of the Dianogist senile estradiol on the as a contraceptive, its effect on the endometrium, thinning it, making it less receptive, its effect on the cervix, making the cervical mucus less and viscid, so it will prevent ascent of the sperm, and its effect on the ovary, the inhibiting the ovulation, so its effect on the ovary, its effect on the cervix, and its effect on the endometrium. One of the concern of the ladies, she will ask you, when I will stop the pills, can I get pregnant immediately? The answer, yes. The fertility after stop of the use of the senile estradiol Dianogist is restored rapidly. And this study shows how the fertility is restored rapidly. And this is the non-pregnant and this the pregnant ladies after stop of the combined oral contraceptive pills containing senile estradiol and Dianogist after 13 months, the fertility will recur rapidly. Come to the fourth point or the fourth item of our lecture. The first was the pharmacology, the second was the efficacy, the effects, and the third was the efficacy, and the fourth is the safety. The safety is very important, and it was found that at the end of the third cycle, the incidence of headache is 12%, breast tension 8%, nausea and vomiting 4%, depression 1.5%, and the edema is 0.5%. But let us see what is the incidence of this side effect after 18 months. The frequency of this side effects markedly decreased, and the headache is only found in 3.5%. The breast tension is only in 1.8%. And only about 5.6% of the women stop the use of the pills due to adverse reactions. So we can come to the conclusion, Dianogist senile estradiol is an ideal combined oral contraceptive pills. It has a unique pharmacokinetic profile, the high bioavailability reaching 96%, 90% albumin bound, and 10% is free, the short half-life. There is no significant change in T3 and T4. There is a minor influence on the lipid and the carbohydrate metabolism and the blood pressure. There is effective cycle control, reduced intensity and the duration of the menstrual cycle, and reduce in the incidence of dysmenorrhea. It is anti-androgenic, so it can be used for treatment of hirsutism and acne. The high contraceptive efficacy, and this is very, very important. The Pearl index is less than 0.1. It's only 0.09 per 100 women per year. And there is no subsequent impairment of fertility. The fertility will recur rapidly after a stop of the pill. What's about the safety? It is well tolerated, and 15 years or more than 15 years use. The incidence of adverse effects are low, and there is a high patient satisfaction. We finished our lecture, but it's very important to have just an idea about the WHO medical eligibility criteria for contraceptive use. This is very important, and we should be aware of all of this. It is cables and wheels, and you can get this wheel. It is very beneficial, and it can let you know what are the contraindications of the combined oral contraceptive pills. But just a hint about the WHO guidelines classified into category 1, where there is no risk, just to say the use of combined oral contraceptive pills or any is safe, any method of contraception. This eligibility criteria contains all the methods of contraception. And the category 1, there is no risk and there is no restriction of use of combined of the method. Category 2, where the benefits is more than the risk, so it can be used. Category 3, where the risk is more than the benefits, so there is a relative contraindication. And the category 4, there is unacceptable risk, and there is absolute contraindication. We will not discuss the category 4, where there is absolute contraindication, and all of us know this absolute contraindication: history of recurrent ischemic heart disease, history of stroke, and so on. The smoking of more than 20 cigarettes with age more than 35 years, there is breastfeeding. All of these are absolute contraindication, and I will not go to discuss it. And even also the relative contraindication, it is well known. The category 3, the relative contraindications, it's well known. Category 2, which can be used, but I will discuss category 1, where there is no contraindication, and there is misbelief or misconception. Can we use the combined oral contraceptive pills in sickle cell disease? The answer, yes. The androgenic progestogen is beneficial, and the risk of thrombosis is theoretical. If we have hypertension, and this hypertension is well controlled, and there is no other risk factors, the patient is not obese, she is healthy, and her age is less than 35 years, there is no contraindication to use of combined oral contraceptive pills. Varicose veins, no contraindication for use of combined oral contraceptive pills. The age above 35 with absence of other risk factors is not a contraindication. Minor surgery, not a contraindication. Obesity, the mild and moderate in absence of other risk factors is not a contraindication for use of combined oral contraceptive pills. The benign ovarian tumors, benign breast mass, family history of breast cancer is not a contraindication for use of combined oral contraceptive pills. This is very important. History of cholecystitis, history of preeclampsia, history of gestational diabetes mellitus, all are not a contraindication for use of combined oral contraceptive pills. History of ectopic pregnancy, history of trophoblastic disease is not a contraindication for the use of combined oral contraceptive pills. Viral hepatitis carrier is not a contraindication. Thyroid disease, simple goiter, hyperthyroid, hypothyroid, all of these are not a contraindication for use of combined oral contraceptive pills. Nulliparity is not a contraindication. The best method of for contraception in the newly married is the combined oral contraceptive pills. Tuberculosis is not a contraindication for use of combined oral contraceptive pills. Epilepsy, combined oral contraceptive pills not exacerbate epilepsy, but there is an interaction between the anti-epileptic drugs which may decrease the effectiveness of combined oral contraceptive pills, and it will cause failure and pregnancy. Uterine fibroid is not a contraindication of combined oral contraceptive pills, and the low dose pills doesn't cause growth of fibroid. The low dose pills will decrease the amount of bleeding in case of uterine fibroid. At the end, I would like to thank you, and as usual, you can find this lecture and more than 450 lectures on my scientific page on the Facebook and also on the slide share. Thanks a lot for you, and thanks to the Techno Pharmaceutical Company.
Thanks, Professor Abu Bakr Nashar, for the very insightful presentation about the role of Dynagest ethinyl estradiol in family planning. زي ما قلت لكم يا دكاتره ان المارتافيفا اول مره ينزل مصر، وهو اول Dynagest ethinyl estradiol يوجد في مصر. To wrap up the importance of Martaviva او الفاليو اللي المارتافيفا يقدر يقدمه للفيميل seeking contraception، تعالوا نشوف فيديو قصير بيتكلم عن المارتافيفا، and then I leave the mic for Professor Amra and Professor Abu Bakr to answer all your questions.
مساء الخير، اهلا وسهلا بحضراتكم. بنشكر شركه تكنو على اللقاء الطيب. برحب بالاستاذ الدكتور عمرو النوري وبشكره على المحاضره العظيمه اللي قدمها لنا، وبرحب بحضراتكم جميعا. ولو كان في اسئله سواء على المحاضره بتاعتي او على المحاضره بتاع الدكتور عمرو فيسعدنا بان احنا نجاوب عليها.
ثانك يو يا دكتور ابو بكر، ثانك يو يا دكتور عمرو على الليكتشر، بصراحه كانت رائعه جدا. انا دعاء قطب، انا برودكت مانجر شركه تكنو، مسؤوله عن جزء الانفيرتيليتي. هكون معاكم في السيشن بتاعه الكيو اند اي، نظرا بس ان ساره عندها تكنيكال ايشو مش هخليها تبقى كونكتد معانا. اول سؤال جاي بالنسبه لدكتور عمرو، فبيقول can I give COC in COVID-19 a patient without the fear of an increased risk of thrombosis?
Well, actually, I think if the patient is having, we can give it in the era or in the time of COVID-19. يعني it's a good contraceptive method, very effective contraceptive method. لكن لو patient عندها COVID-19 هو المفروض إن هو يبقى فيه عندها already isolation. definitely we know that the risk of thrombosis أحد اللي هي causes of morbidity and mortality اللي هي بتحصل. ف it goes without saying that at that time المفروض إن هو there will be no sexual intercourse, there will be complete isolation, and then also we know that there is a high risk of thrombosis. So really, I think we have to stop the combined oral contraceptive pills at that time. There should be no really actually intercourse at that time whatsoever, يعني, unless they are actually want to attract اللي هي الvirus from the other partner.
Dr. Dua, I would like to add to this question the answer of Dr. Amr about the sexual intercourse. It is also recommended for the suspected patient not to have a sexual intercourse. It is also recommended for the high risk not to have a sexual intercourse. ودي بتاعت نيويورك سيتي سيرفيس، ده الريكومنديشن بتاعتها للسكشوال انتركورس during الايرا اوف كوفيد. حتى قالوا كمان السكشوال بوزيشن ايه لو احنا عايزين نعمل لابد يكون سيف 6، لان هو ده الكونتراسبشن از هايلي انديكيتد. وزي ما تفضل الدكتور عمرو ان هو لو هي واحده عندها كوفيد فاحنا مش هندي لها كومبايند اورال كونتراسبتيف بيلز، ومن البدايه خالص ما يبقاش فيه سيكشوال انتركورس.
تمام، ثانك يو يا دكتور عمرو، ثانك يو يا دكتور ابو بكر. السؤال اللي جاي للدكتور ابو بكر، as a Dynogest is 17 times more potent than Gestodine. Does this mean that Martaviva is more potent as a COC than other brands?
Yes, that's right, and we explained why it is the efficacy as contraception is high. It is attributed to 3 factors: the inhibition of implantation due to the high efficacy of the Dynogest. It is 17 times higher than the other types of gestagen. It will decrease the endometrial thickness, and it will prevent the implantation, and also it has an effect on the cervix, decreasing the cervical mucosa and making it more viscid. It will prevent the ascent of the sperm and its effect on the ovulation. So we have 3 mechanisms for the contraceptive efficacy: ovulation inhibition, implantation inhibition, fertilization inhibition.
Thank you دكتور. دكتور عمرو، في سؤال: is a pregnant woman with HELLP syndrome more liable to deterioration if she is infected with COVID-19 than other pregnant females?
Well, it's a very difficult question to answer. Where Ali a query, it was raised in some of the discussions related probably here the receptors والprotein والACE2 اللي هي angiotensin receptors. It's a very theoretical risk, لكن in reality there is no actually any evidence that suggests that it increased the preeclampsia in the patient of COVID-19. We know that they are probably they will be immune compromised and they will be at risk of several types of disease and probably maybe liver and renal failure at the end stage. So this may be confused actually with the HELLP syndrome. But again, up till now, there is no evidence from research that this is increased. It is a theoretical risk rather than a clinical evidence-based risk. Thank you.
Thank you دكتور عمرو. دكتور أبو بكر، السؤال اللي جاي بيسألنا عن الإيفكت بتاع الداينوجاست، تمام، as a marta-viva على female suffering PMS symptoms and dysmenorrhea. Is it more effective due to inflammatory effect of the Dynogest?
The answer yes, it is very effective as regards the treatment of the relief of dysmenorrhea. And for the premenstrual retention syndrome, we should look for the cause, and it may be one of the treatment to use it.
تمام. Another question about do you recommend a continuous regimen of Dynogest ethinyl estradiol as an effective treatment for endometriosis, and for how long?
Yes, I am recommending it because as we mentioned, it has anti-proliferative, anti-inflammatory, and anti-angiogenesis, and all of these are the theories of the endometriosis. According to the guidelines, the first line of treatment for the endometriosis-associated pain is combined oral contraceptive pills, and it is recommended not to be cyclic, but to be continuous, because this will give a relief of the pain for a long time.
تمام. Thank you يا دكتور. دي كانت تقريبا معظم الأسئلة اللي جات within ال two options دول أو ال two issues دول. Thank you يا دكاترة على الدكتور البروفيسور أبو بكر والبروفيسور عمرو. Thank you يا جماعة على الحضور الجميل، وإن شاء الله نتقابل تاني في الويبينارز الجاي. Thank you.